A lot more of the anesthesiologists supported it. And then 18 months later, uniformly, everybody in their department supported having only video laryngoscopy. And the reason that they said was they felt it was better for patient safety, team dynamics, human factors, quality of care, and quality of training. So they changed after being forced to use them for a period of time. Their attitudes totally changed. And then for many of us, it's the same. We're so used to direct laryngoscopy, we don't want to change, even though it might be good for us. And the last study I want to show you is one that's done in the pre-hospital setting, where they looked at a protocol where they used the CMAC, again, this video laryngoscope, and a bougie in all rapid sequence intubations. And so this was done in Finland, where for a period of time, they said you're going to use video laryngoscopy and a bougie, in particular it was a Frova introducer for all intubations. And then they compared that 22 months where they were doing that to the year before where you were able to do direct laryngoscopy. And here's what they found. Before using video laryngoscopy and the bougie, the first pass success rate was 85.7%. After being forced to use this protocol, using the bougie and the video laryngoscope, it increased to 98.2%. And think about it, intubating, doing RSI in a helicopter is a difficult airway situation. And here they went all the way up to 98%. And it begs the question, we always think of video laryngoscopy as a rescue device or a difficult airway device, but what if we used it routinely? What if we used difficult airway devices routinely? We can see that we would have an increased success rate, which we all want, and that, again, a bougie may be easier to pass with a video laryngoscope than an endotracheal tube. So a couple of takeaways from this study. So finally, what do we know? What's the bottom line? What can we say about video laryngoscopy? It improves the view of the glottis. It may improve first attempt intubation success rate. Remember the study I reviewed from Peters et al., 95% success rate with video laryngoscopy compared to 86% for direct laryngoscopy. The Cochrane review found that it may reduce the number of failed intubations. Again, fewer failed intubations when for overall and also when dealing with difficult airways. We know that it's already become part of our difficult airway algorithm, but it may be the primary approach for all intubations in the near future. And if you're using a device like I like, and I don't have any ties or affiliations with stores or the CMAC, but a device like CMAC, which allows you both direct and video laryngoscopy, is a device that might allow you to embrace the future without abandoning the past. And so those are my big takeaways about video laryngoscopy. And I want to thank you for your attention. Thank you very much.
Thank you very much, Dr. Madem, for fantastic presentation. Any comment or question? Yes, please.
First of all, welcome to Turkey and thank you for your presentation. I want to ask that I work in a hospital where approximately 1,000 patients apply per day. And I think that means that we manage disaster every day. And in my country, there are so many centers. While we are examining the cold or myalgia, on the other side, we may need to intubate the patients. And I think it's more difficult about us. What do you think about the practicality of this process in crowded emergency departments? Thank you.
Thank you for your question. I believe the question is that in settings where maybe you have less experienced providers, yet are crowded, what about having a device like this in those settings? And I think, you know, it's, the studies pointed out, those who are less experienced with intubating actually showed the greatest benefit in first pass success. And so it probably behooves us, if you're intubating all the time, you might have some expertise, but if it's an infrequent procedure, having a video laryngoscope might be of benefit, especially if you're doing it infrequently. But the other study I showed also revealed that even in experienced hands, it's hard to know when we're going to encounter a difficult airway. So rather than take a chance, my feeling is that we are progressing towards where we'll be using this exclusively, and that direct laryngoscopy will be something of the past.
Okay, thank you very much. Any another question?
Yeah, here, yeah. Okay.
Okay.
No, Basar, I have a question.
Okay.
Thank you very much for this nice presentation. And it's clear we have the evidence for using this kind of tools. My question is, do you have information about the cost? You know, if you compare CMAC to the direct, laryngoscopy, this is very important, for different countries in the world.
So the question was a very good one, which is it fiscally responsible to replace a device that may be working with something that may be more expensive? There's two ways of looking at it. If you already are adding a device like a CMAC as a rescue device, then you're already purchasing it anyway in addition to the direct laryngoscopes. And the other one is more philosophical, which is that if your complication rate goes down and you have one less patient who has anoxia as a result of a difficult airway encounter, and the hospital isn't sued or doesn't lose money as a result, or the family doesn't lose money as a result, then that could justify, that cost savings from fewer complications could easily justify the cost difference between a laryngoscope and a video laryngoscope.
Okay, thank you very much. Last question, please. Last question. Yes.
Thank you very much for your presentation. I will ask, you said that some kind of video laryngoscopy is better than direct laryngoscopy in difficult intubation, but was it expected difficult intubation or unexpected, or was it well-designed criteria?
In the study that I presented, it was anesthesiologists who predicted a difficult airway based on patient characteristics or prior knowledge. And in that case, video laryngoscopy was more effective, even though they were experienced. But there was one study that I presented also that just shows we are not good at figuring out who is going to be a difficult intubation or difficult mask ventilation. And that's the problem. If we could just look at them and say, oh, you've got a beard or you've got a short neck, you're going to be a problem. But we've all encountered somebody that we're really worried about, and then we go in and it's an easy intubation. And we've also had patients where we say, oh, they've got a long neck, it's going to be fine, and then you go to try and intubate, and it's much more challenging. And so it's just, we don't have good tools. And we should just, basically, my feeling is approach every patient like they're going to be a difficult intubation. Thank you again for your question, and thank you for your attention. Thank you. Thank you.
Next speaker. Very important topic for emergency medicine, new topic. Reboa in ED, Dr. Yosuke Matsumura from Japan. Thank you.
肺結性 E 群らベニムアディムヨスケ松村ジャポニアダンゲティム I'm an emergency medicine physician, and I also cover the ICU. And my another subspecialization is endovascular therapy. I cover the interventional radiology and of course reborn, and I also love to perform ECMO. So I am very interested to be here. Thank you for having me. So here's my disclosure. So let me introduce some reborn practice in Japan. So this is the procedure video. The first thing you need to do is get the access. The access at the common femoral artery. You need to puncture between inguinal ligament and bifurcation. Of course, you should use ultrasound routinely. You can see the bifurcation directly. And you advance the guide wire to the aorta. Then remove the needle and insert the arterial sheath over the guide wire. Then you can put the reboard over the guide wire. In this setting, the balloon is going up to zone 1. And next step, you need to exchange the guide wire for a stiff wire. This stiff wire will strengthen the shaft of the catheter. Then, then you can inflate the balloon. So by the way, the term reborn was published in Journal of Trauma in 2011. But in Japan, we start to use reborn catheter in 1998. So we have a very long history. Oh, sorry. But unfortunately, we didn't publish a lot of research paper in this field. 2003, 2009, 2015. Sorry about such long silence. Only small case series were published from Japan until 2015. But in this year, one case series was published in Journal of Trauma. The title is Safety and Feasibility. But I need to give a question to this paper because they reported the rate of lower limb amputation at over 20%. Surprising number. Next year, another paper was published. This is a database analysis using a propensity score match analysis. And they reported higher in-hospital mortality in reward group. This is negative data from Japan. A similar study was published very recently in JAMA surgery from the United States. This is again propensity score matching. And they reported higher rate of AKI, amputation, and high 24-hour mortality in reward group. So lower limb amputation. These two studies, the research period was before 7 French reward device. In the United States, they used to use 12 French, and in Japan, we used to use 10 French catheter. But now, we have 7 French small profile reboard catheter. So probably this problem can be solved with such small profile catheter. This is our publication. So we demonstrated the fewer complications in small sheaths. We didn't require any fasciotomy, amputation, or PTA. But what about higher mortality? How should we use reboard? One possible answer is here, algorithm. This is the classical algorithm suggested by Shock Trauma Center in the United States. And this is another algorithm from the Denver. This is another algorithm presented in the Western Trauma Society. How many reboard algorithms do we have to learn? I hate to memorize many things. I believe to learn trauma strategy is more important to learn algorithm. So this is the summary of today's my talk. The first is thoracotomy plus reboard can be the good solution in a critically ill patient. And second is early access, undelayed but short occlusion. These are the key issues for the successful management of Reboa. And third, I'm going to mention the education and research briefly. So let me introduce our recent case. 17-year-old boy, he fell from 11th story of the building. Actually, he jumped from the building. He collapsed 5 minutes before arrival, and CPR was initiated by the EMT. So first, we performed resuscitative thoracotomy and aortic cross clamp. And he was resuscitated after 8 minutes of the CPR, and chest X-ray didn't show any significant injury. And the fast exam was negative, and pelvis showed the fracture. So I identified the cause of the shock was here. So we got bilateral arterial access and the large venous access, and massive transfusion was initiated. Then the fast turned positive at right upper quadrant. So I decided to go to laparotomy first. Can you see this picture? Before going to the operating room, we converted thoracotomy to zone 1 Reboa. And the patient was transported with partial Reboa. And in the operation room, we could deflate the Reboa within 20 minutes, and the surgeon found a liver injury. But it was not so severe, and fortunately, no other organ injury was found. Instead, retroperitoneal hematoma was expanding rapidly, and so the surgeon simply performed perihepatic packing, and abdomen was left open. And next, this is my turn. I embolized bilateral internal iliac artery approximately within 10 minutes. And now, we didn't see apparent extravasation in this patient. Now we scanned the patient, but we found a chest wall bleeding. So we reclosed the chest wall in the ICU. So first, the thoracotomy plus Reboa. So we performed thoracotomy first, then converted Reboa. So this is a comparison between thoracotomy and Reboa. The thoracotomy is absolutely more speedy and definite, but we need to make new chest wound, and sometimes the chest wall bleeding is significant, and thoracotomy may induce hypothermia. The Reboa is less invasive and adjustable, but we need to puncture the common femoral artery. Sometimes this is troublesome, and the patient has a leg ischemia. So this, in Japanese educational course, we suggest this strategy. If the patient is impending cardiac arrest, or if the patient doesn't have arterial access, don't hesitate to do thoracotomy. But if the patient is shock but not cardiac arrest, and the patient has the arterial access, consider the Reboa. This is a comparison between thoracotomy versus Reboa. So one study showed the benefit in Reboa, and the other did not. This is a study from the United States. They concluded Reboa has a benefit in selected patient. What is a select patient? It means no CPR, but hypotension at arrival. But do we have to compare thoracotomy versus Reboa? My answer is no. We can perform these two aortic occlusion methods in one patient. I know thoracotomy is not strongly recommended in pulseless blunt trauma patient. And of the 106 trauma Reboa patient, we experienced 30 thoracotomy plus Reboa population. And of these, 6 patients survived. And interestingly, all of them received CPR before Reboa. It means thoracotomy plus Reboa may give a chance even in a pulseless blunt trauma patient. Theoretically speaking, conversion prevents hypothermia, and closing the chest may prevent the chest wall bleeding. The second, the early access. So we obtained arterial access simultaneously with thoracotomy. So we got bilateral arterial access. In the top stent textbook, this was published by the EVTM Society, the guys with the Swedish or European guys, and we suggested AABCDE concept. What is AA? Airway and access come first. Of course, there are some disadvantages in arterial access, such as the vascular injury or hematoma, but delayed access can lead to more significant catastrophe, like less palpable cardiac arrest, more hematoma. So I investigated the benefit in arterial access in REBOA patient. So I analyzed 109 REBOA patients, and naturally, in non-survivors, presented a higher ISS and lower SBP, pre-occlusion, lower SBP, and longer total duration of occlusion. And non-survivor showed longer arrival to access. The survivor got access earlier. So I performed a binary logistic regression analysis, and the result showed arrival access time was significantly associated with the survival outcome. The odds ratio of 0.989 seems small number, but this is every minute. So if the access delayed 10 minutes, the patient's survival rate decreased 10%. This is a big number. And then I defined the cutoff value about 20 minutes. In early access group, they showed significantly better survival curve. So I believe there is a benefit of early access in REBOA patient. And next, the undelayed but short occlusion. We could deflate the balloon within 20 minutes. So how long can we occlude? This question is very good but difficult to answer. So I couldn't answer this in a good answer, but the survivor shows the pre-occlusion pressure of 70, and survivor shows total duration of occlusion of 30 minutes. So this is not the cutoff value, but undelayed but shorter occlusion can be will lead the successful management. So there is a different tram system in the world. So let's compare Japan, Turkey, and the United States. So I found a lot of similarity between Japan and Turkey. For example, I'm in emergency medicine, and we are responsible for the resuscitation of the patient. But in the United States, the statement recommend acute care surgeon or vascular surgeon should perform the REBOA. But in Japan, we, emergency medicine, perform REBOA. So in my mind, resuscitation must not be delayed, so first responder should perform REBOA. So in this country, this is you should perform REBOA. Because emergency medicine, we have the good friend, ultrasound. We can see the bifurcation of the confemoral artery, and we can see the guide wire in the aorta. This can lead to safe procedure. And next, the patient population and the mechanism of injury. We have a lot of geriatric population, so we often have the coagulopathy, and we often have such tortuous aorta. So you may encounter such difficult patient. So that is why education is very important. So regarding the education, the endovascular workshop is the key education, key occasion. And there are several endovascular workshops in the world. We start the DIRECT Society. DIRECT means Diagnostic and Interventional Radiology in Emergency and Critical Care and Trauma. We start a workshop in 2011. and we create a program including such a simulation or a 3D vessel model. Sometimes we use live animals, sometimes we use cadaver. This is zone 1 occlusion, this is a zone 3 occlusion. And in the United States, from 2013, the BEST course, the Basic Endovascular Skills for Trauma, started in the US. The shock trauma is the center for the BEST course, and I've been working as a visiting researcher here, so I supported the course. And from 2014, in Sweden, the EVTM, the Endovascular Resuscitation and Trauma Management workshop, started. I met the Turkish colleague here, the Dr. Acil, Dr. Uzleb here. And in the UK, from 2016, and they are teaching to the emergency medicine and the paramedics. This is a very unique system. And last year, South Korea started the similar course. Then finally, I will mention the research briefly. Ribora seems very useful tool, but don't forget, we have negative data from Japan and from the United States. I found some limitation in this study. The higher AKI, higher amputation, higher 24-hour mortality. So I wrote the letter to the editor, to the editorial office. Looking at the table in detail, the reward group shows the SBP of 109 and GCS was 14. The patients are too stable. And this is the comparison between survivor versus non-survivor. The survivor patient showed SBP 140 and GCS 15 and head AIS 0. So probably, the survivor received only 1 unit of transfusion of red blood cell, plasma, and platelet. So the patients were too stable to require reward. Probably in the United States, they are overusing reward. So this suggests unnecessary reward placement in a stable population, and it induced the unnecessary complication. And then they didn't consider the physiological derangement, so resuscitation time bias might decrease, may happen. So ideally, time-dependent propensity score matching should be performed. So we are going to start the international prospective observational study in the very, very future. So in conclusion, the thoracotomy plus reward that may give a chance in blunt cardiac arrest, and early access and delayed but shorter occlusion, these are the key issues for the successful management. And education and research, it means endovascular workshop and international multi-center study, these are required. So let's proceed education and research together. 이기니 için teşekkür ederim.
Any questions from the audience? Yes. 1 second, microphone's coming.
Congratulations, it has been a great talk. I have a couple of questions just on the base of your results. And first of all, I agree 100% what you said about the need of more data, multinational study, and also this allow me to emphasize the importance of angiography into the emergency room. One question would be, in your experience, you are using a less dimension French catheter. That is going to be less occlusive, and then is ameliorating acute kidney damage and limb acute ischemia. But on the other side, I assume that is going also to not reduce too much the hemorrhages. So this is the reason why you are taking 10 minutes. Assuming that I'm not going to take a TC scan that is actually mandatory in polytrauma patients, I will use echo. I think there is other solution that I know that is the cardiosurgery used today. They put a hole in the way that is the catheter make occlusion, but another part of a catheter is going to give blood. So I think the technology we should together to think about the different catheter they use in cardiosurgery. Because I don't like the idea to use too much my question is, how much is the bleeding in your less French dimension catheter compared to occlusive one?
Bleeding from where? Bleeding from the organ or bleeding from the...
I mean, using a less French dimension, you have more bleedings, right? Because you are not making occlusion.
No. Oh, even in the small proper catheter, the
Yeah.
balloon can occlude the aorta completely.
So which is the value?
Yes. So, but as I mentioned before, the small shaft, sometimes the balloon can migrate downstream, but the balloon can occlude the aortic flow completely. The balloon sizes are same.
Okay, understand. And then what about the opening another hole downstairs?
Yeah, that can be a good idea. We often use in
We are
ECMO.
using that.
Yeah, but this is technically difficult. So we need to the skilled surgeon and ultrasound, hopefully in the fluoroscopy.
I agree.
Thank you very much. Any another question or comment? Okay, I want to know, after last topic, we have very fantastic opening ceremony. It was to join all to this fantastic, I think, never seen like this opening ceremony till this time. So, and after the opening ceremony, we give book for everybody, okay? Thank you very much. We can continue. Yes. Yes.
Next, I'd like to introduce Acil.
Bu alttaki yazıları görebilir miyim? Okay. Hello, everyone. It's a great pleasure to be here with you today. We have seen excellent presentation about the future of the emergency medicine. The last presentation is about REBOA and EVTM. In Turkey, EVTM concept started in 2018. I hope it will be lead to use angiography in emergency medicine. Dear Dr. Talhörer, he is not here today, and our friend Dr. Yasuka Matsumuro helped us so much for EVTM concept. Also, I would like to thank to Dr. Jander for supporting us in the learning of this concept. Here is some problem, I think. I can't control this. Evet. Geçiş yapamıyorum.
Beyler bir sonraki slayta geçebilir misiniz mi? Tamam, bir deneyin hocam.
Sona attı. Home. En başa gelmeniz lazım.
Kaç? Hemen bir en başında. Tamam hocam.
Evet.
Tamam, buyurun hocam.
Bununla.
Onunla da yapabilirsiniz öbür videoda.
Tamam.
Tamam, nasıl harcayın?
Okay. Sorry about it. ECMO can be used in many different situations in the emergency room, especially in case of cardiac arrest. Its use has become widely accepted and widespread in the world. In addition, ERDC and cardiogenic shock due to intoxication and pre-arrest conditions such as pulmonary embolism or other indication in the emergency department. Resuscitation is one of the priorities of emergency medicine. In spite of all efforts, it's not possible to achieve satisfactory results in conventional CPR. Survival of both in-hospital cardiac arrest and out-of-hospital cardiac arrest treated with conventional cardiopulmonary resuscitation is very low, estimated at 20 and 10% respectively. Use of eCPR can restore perfusion more rapidly and can prevent mediator storm. A recent meta-analysis of 6 trials containing 2,200 patients concluded that eCPR improved both survival and long-term neurologic outcome. Here are the results. Here are some observational studies about eCPR. First one is from ALSO registry. 270 patients were included to study. Percutaneous cannulation rate was 70%. 1/3 of the patients underwent coronary intervention. Median duration of ECMO was 47 hours. Overall survival rate was 27%. The second study is from Canadian ECLS organization registry, and nearly 3,000 adult patients cardiac arrest over than 15 minutes duration and not responding to conventional treatment was included in the study. Okay. The third study was systematic review of adults with refractory out-of-hospital cardiac arrest. Survival rate was 22. Refractory circulatory shock and severe ERDC, which occur in poisoned patients, is still a challenge to treat. Hypoxemia from ERDC results in multiple organ failure, which is incompatible with life. ERDC is still a severe lung disease with a high associated mortality rate. In the most severe forms of the disease, mortality rate may exceed 60%. First successful clinical application of ECMO for ERDC was described in 1972. Until 2008, only 100 patients per year in which ECMO was used for ERDC. Following the influenza A pandemic in 2009, there has been a significant increase in VVA ECMO utilization. In the last 5 years, more than 400 cases per year of VVA ECMO for adult respiratory failure have been reported in the ALSO registry. Now let's look at the VVA ECMO studies. First one is EOLIA. Randomly assigned 249 ERDC patients included the study. They compared conventional therapy to VVA ECMO therapy. There was 11% lower mortality rate in ECMO group, but not statistically significant. The study was terminated because the analysis could not reach the expected mortality decrease rate of 20%. The second trial is CESAR trial. ECMO significantly increased survival without disability at 6 months compared to conventional management. This is a very good study for ECMO, but there is some limitations. There is a lot of patient crossover the ECMO group. Okay, case from Turkey. This is a patient who had ECMO therapy in my clinic. He was found unconscious in bathroom. He was diagnosed with major depression and has a history of psychiatric medication use. He was suspected of having a large amount of medication from his own drugs. The benzodiazepines was positive in the urine drug tests. So we administered flumazenil, but he did not respond. After that, lipid emulsion therapy was started due to worsening condition. Patient did not respond to lipid therapy either, and therefore the patient was intubated. On the second day, hypoxia occurred, and despite the low volume protocol, hypoxemia worsened. On the third day of his admission, the patient was diagnosed with ERDC due to severe hypoxemia and radiologic findings. Then patient connected to ECMO. ERDC may be occurred due to the drugs, or it may be developed due to our lipid therapy. I need help again. This is a short video from the cannulation process of this patient. In case of intoxication, VA ECMO is usually required due to cardiogenic shock. Our patient was a ERDC case, but we use VA ECMO, not VV ECMO, because we worried about hemodynamic of patient will deteriorate in following days.
Anlayamıyor şu an.
Nasıl sabitliyorsun ya?
Okay. Pulmonary embolism is an important cause of death in the emergency department, as you know. There are very few centers in Turkey that are able to make thrombectomy, and they are not available 24/7. Thrombolytics are the only treatment option in the cardiogenic shock and arrest due to pulmonary embolism. ECMO can provide support to patient until the clot dissolves or until the thrombectomy is performed. Yusuf and colleagues published a review of the reported case of the pulmonary emboli managed with VA ECMO. A total of 78 patients were reported. Half of them had a cardiac arrest. Overall survival rate was 70%. For patients who presented with cardiac arrest has a survival rate of nearly 50% compared with historical rate as high as 75%. Now, I want to talk a little bit about the ECMO process because the emergency staff is new in this area and there are important points to consider. ECMO is a risky and expensive procedure. Criteria for the initiation of ECMO include acute severe cardiac or pulmonary failure that is potentially reversible and unresponsive to conventional management. Peripheral cannulation is performed either percutaneously or by vascular cut-down. Ultrasound guidance is mandatory. Advantages of percutaneous cannulation include decreased bleeding and infection risk. Percutaneous cannulation is more suitable for emergency physicians, but emergency physicians should also know about the cut-down method in order to apply them when things process go wrong. Many physicians prefer the right femoral area, both artery and vein cannulation for VA ECMO. And for VV ECMO, right or left femoral vein and right jugular vein preferred. Sometimes an extra second venous drainage may be required to increase the amount of the blood in severely hypoxemic patients. Maintaining optimum blood stream is the most important and difficult part of the process. Blood stream is affected by cannula dimension, body fluid volume, and resistance to reinfusing current. The revolution of the pump is defined by per minute RPM. If you increase RPM, the blood flow and also blood pressure increase, but it causes negative pressure at the venous tip. High levels of pressure cause erythrocyte trauma. Another important part of the ECMO is anticoagulation process. Heparin is used for this purpose. If the heparin is contraindicated, direct thrombin inhibitors can be used. Platelet counts tends to decrease, so we should follow them, and the circuit should be observed for thrombus. When we are taking weaning decision, we have to see improvement in radiographic appearance, pulmonary compliance, arterial oxyhemoglobin saturation, and ventricular output. Then we can go to weaning trial step. In weaning trial step, for VV ECMO, it performed by elimination gas transfer and while maintaining the blood flow. For VA ECMO, it performed by clamping both drainage and infusion lines. The patient must follow at least 6 hours, then we can consider to decannulate. Severe bleeding from arterial site is the main problem in the decannulation step. For VA ECMO, at least 30 minutes of compression is required. Also, vascular closure device can be used. Bleeding occurs in 30 to 50% of the patients who receive ECMO, and it can be life-threatening. On the other hand, systemic thromboembolism can be occur as high as 16%. We should know about managing serial arterial bleedings. We must have experience bypassing the leg to ensure blood supply. We should know what is special conditions such as left ventricle decompression, such as coronary and cerebral hypoxia, and etc. Lots of things. The priority of ECMO is eCPR in emergency practice. ECMO can also be used in the ERDC and cardiogenic shock, particularly which caused intoxication, post-restorative syndrome, and acute coronary syndrome, and pulmonary embolism. Emergency medicine professionals should know which patients can benefit from ECMO. ECMO management requires a trained and experienced team. Okay, at the end of my presentation, there's a question here. This one or this one, which would you like to have? Yes, I know your answer. Last words, in many diseases, the patient should be kept in life until the treatment heals the patient or until the body overcomes it. Many patients die because they cannot exceed this critical threshold. We must help the patients to overcome this threshold, and ECMO can do it for us. Of course, it is not an elixir of immortality. We just had a new bunker to survive until attack ended. The first thing we need today is to reduce the costs of ECMO, because ECMO costs are not only our problem, but also the problem of developed countries. In the future, we need a device that's smaller, more practical, and easier to manage. Okay, thank you.
Thank you very much, Dr. Mücahit. Yes, ECMO it plays in the future of emergency medicine. Any question or comment? Okay, thank you.
Thank you very much.
It's time. Sorry? Okay, thank you very much. After 10 minutes, we will start opening ceremony. Arkadaşlar 10 dakika sonra burada toplanalım. Açılış töreninde herkesin burada olmasını istiyoruz. Gerçekten çok özel bir tören hazırlamış durumdayız. Şimdiye kadar gördüğünüz törenlere benzemiyor. Bu törene katılan arkadaşların hepsinin zaten isimleri de burada belli. Onlara da kitap hediye edeceğiz. Onun için hepinizi burada bekliyoruz. 10 dakika sonra. 10 dakika sonra buradayız.
This year Congress is another scientific feast with more than 75 foreigner participants from more than 43 countries. On this meaningful day, now I would like to invite Professor Luis Garcia Castrillo Riesco, President of the European Society for Emergency Medicine, USEM.
Good evening to everybody. Yes, I come from this small country that looks like a square, and it's at the end of Europe, as far as Turkey is. So we are in the opposite side. I am really pleased to be here. It's not my first time. Fortunately, I have been with you during the last 4 congresses, and I hope that in the future we can share also our experience here in this wonderful venue. I am also pleased to be the USEN representative, very proud of, But I have to say that I am not the only member of USIN. Fortunately, to show the support that USIN is providing to your organization and to this Congress, we have an extended group of members of the USIN board. We have past presidents, board members, and I will say future presidents with us today, acting as speakers and taking part in this Congress. But there is a small problem. The organization offers me the opportunity to share some thoughts with you, and I don't want to resign this offering. So in the next minutes, I am going to share with you some personal thoughts. As president of USIN, during the last years, in my mind it has been struggling the idea of what is the role of scientific societies. And I want to share now with you my ideas. We are all going to agree in the idea that the first objective of a scientific society is to look for the excellence in the care of the patients. And for doing so, we have two tools. One is the continuous medical education, and the other one is research. And this Congress is a good example of both things. Here we are going to be exposed to the state of the art of the situation of care. We are going to be exposed to new technologies. We are going to be exposed and trained on skills. And this is one of the objectives and the main objective of a scientific society. Research is the other one. And here we are going to see the last results of research. But mainly we are going to join other colleagues here, and we are going to think about research ideas. We are going to do exchanges of opinions in between us. Our learning is not going to come from the speakers only, it's going to come from the speakers and from the colleagues. Probably discussing a poster, we are going to learn as much as hearing a speaker here in this room. I want to say that after the Congress, the scientific society work is not finished. It has to continue provide updated information, and this is done through journals, letters, workshops, online systems, and all this is part of the activity of the scientific societies as EPAD and as EUSM. But this is not the only role. I would like to stress the idea that scientific societies has to be opinion leaders. We have to create guidelines, we have to promote the established guidelines, and we have the ones to have the knowledge to define the type of care that we have to provide to our patients. We have to define the systems of care, and with system, I include the pre-hospital part of our activity and the in-hospital part of our activity. It's impossible to think on emergency medicine without these two elements. And the scientific societies has to lead and have to be the opinion leaders on this. But we don't have to forget that we are working for a specific society, and our society is continuously changing. When I started doing my work, the society was completely different as it is now. Changes occur continuously. New diseases are appearing. New problems are appearing. New procedures are offered to us, as we have seen with the previous speakers, and we have to adapt to these circumstances. We are commonly exposed to the idea that the society is aging, and with the aging of the society, more fragile patients are arriving to our departments. But that is not the only problem. Isolation is a huge problem. You know that in Europe, 30% of the houses are occupied by only one member, meaning that the society is losing the network of the social group. And this is going to offer a new situation to our departments, to our services, and we have to consider and take in consideration this aspect. To deal with all these problems, we cannot do it alone. The scientific societies cannot do these things alone. So we have to look to generate links and synergies with other organizations, with other scientific societies, with other groups, with other federations, not only dealing with emergency medicine, but also dealing with other aspects, social aspects, technological aspects, and we need their collaboration. But mainly we need the collaborations of individuals. And from here I encourage everybody who is not a member of a society to become a member of a society and be part of this big project that I have been showing you. For those who are members of our societies, I encourage them to be more active. Probably my words are going to be taken also by IPAD. We have our hands open and looking for more members to collaborate with us. Now I would like to finish these brief commentaries expressing my gratitude to the organizers that allowed us to try to reach our goals, to improve the education, to improve the research, to improve the network in between the groups. This Congress is the right place for do all these things. So thank you for the organizers.
Thank you, Luis Garcia Castillo-Resco, for your opening remarks. Now, I would like to invite Professor Jill McEwen, past president of the Canadian Association of Emergency Physicians.
Good afternoon, ladies and gentlemen. President Professor Dr. Bajar Kandar, Emergency Physicians Association of Turkey, Organizing Committee. As the past president of the Canadian Association of Emergency Physicians, I'm honored and delighted to attend your 6th Intercontinental and International Emergency Medicine and Critical Care Congress and your 15th Acil TIP Congresi here in Antalya, Turkey. I'd like to thank the organizers for their kind hospitality. You know, it's the 5th time that I've been here in Antalya, and each time I come, it gets more, the quality of the conference gets better, and I'm very impressed with everything that you guys are doing here. It's fantastic. I'm also an emergency physician like you and have worked for 32 years at Vancouver General Hospital in Vancouver, BC in Canada, where we see over 100,000 patients a year. I've had a few other positions as assistant dean in UBC, University of British Columbia, and continued to be the undergraduate education program director at UBC. So I'm going to begin by telling you just a little bit about the Canadian Association of Emergency Physicians. We have about 2,500 members who represent the EPs of Canada. And we are organized around 4 pillars, very similar to what we are doing here. So education and research are 2 of our top priorities. We do an annual conference, and our conference is coming up in May in Halifax, Nova Scotia, and all of you are invited. If any of you are able to attend, we would be delighted to have you there. We also have road shows throughout the year, and we do some other continuing professional development activities across our country. Research, we offer modest seed grants to researchers in Canada that have led to some pretty impressive careers. And we do, the Canadian Journal of Emergency Medicine is our association's journal. The other 2 pillars are advocacy, and we advocate for the specialty of emergency medicine, mostly for our patients and also for emergency physicians in Canada. And our 4th pillar is advocating for emergency physicians. So we have a number of committees and special interest groups that our members can join, and whatever their interest is, and to connect and promote various subspecialties of emergency medicine. But no matter what country we come from, we emergency physicians have a lot in common. So the pride and enthusiasm that I see amongst my colleagues at home, I also see in all of you and in this room and in all the countries that have emergency medicine conferences. So no matter where we come from in the world, I think that we share the common attributes for the fast-paced emergency treatment of our patients, the unique opportunity to be a part of our patients' lives 24 hours a day, 7 days a week, from all socioeconomic statuses, and the ability to quickly diagnose and treat conditions from all walks of medicine. So I don't think global boundaries separate us. And, you know, we are truly blessed to have such an amazing career and be part of our patients' lives in the world today with all of the division and the tumult that is happening all around us. There's no better time for us to get together at international conferences like this to share our knowledge and to become friends with each other. So I'm really happy to be here. On behalf of CAPE, I wish you all an excellent conference, and I hope you all learn a lot from both the academic sessions and the research that has been done and from connecting with each other. And thank you for your attention, and once again, thanks for your hospitality.
Thank you, Jill McEwan, for your opening remarks. Now I would like to invite Professor Carlos Garcia Rosas, first president and founder of the Mexican Society of Emergency Medicine and Mexican Academy of Emergency Medicine.
This is Latin flavor. We have on the brain, we have on the veins, on the heart, the feeling of the. First of all, I want to thank you for the organization to invite me to be here. Really, it's nice to be here to share a couple of words that we want to do. Let me tell you briefly about my life. I born in this town 33 years ago. No, just kidding. It looks like, but no. I born in this town. They are really a small town. The town, the particular thing is that they have founded by British. We have Bull Ring, the church, and the symbol of the city is the railroad because this is part of the connection between the Gulf, Mexican Gulf, and the Mexico City. And then I moved for the university because it's a small town, they don't have medical school at that time. I moved in 1986. Mexico City, the name is Distrito Federal. Everything is changing. Now the name of the Mexico is Mexico City, that's it. So I live in Coyoacán in Mexico City. It's a small county in the big city, very nice neighbor. And when I started 33 years ago, probably many of you, they don't have that date. 33 years ago, we started emergency medicine in Mexico. So we don't have men control the emergency room. The land is like desert. We don't have rules. We don't have program. We don't have regulation, anything. At that time, we start to build everything in Mexico City. But it's not easy because we arrived like monkeys. The king of the jungle was the surgeon, and if something happened very strange, they call for the internal medicine because they have a very strange diagnosis. I don't know what, but they think that they know. Over the years, when we started in Mexico City. This is the pioneer of the Mexico City and the Latin America. 15 people started the emergency medicine program in Mexico in '86. And this, believe me or not, I am one of these. These 4 people, we organize the society, we continue to organize the board, we organize the Mexican Academy, and we organize the World Organization in Emergency Medicine for the rest of the world. And then in 1994, we sprint for more than 60 places teaching emergency medicine now in Mexico. But we not promoted. The best promoting for you and for me, because we are relatives, only different is the language, but we saw similar patient, we are similar life. The best promoting was the ER talk show. They have 10 years on the top in the television and spread the rest of the world. Now the people know a little bit more about what the emergency physician doing. And they have different top shows in different countries in different language. This is why one of the things I am worried about, to know the artists and say, well, who is these Hollywood people doing? And I met, do you remember this nurse? The nurse was for the TV show. And then I came in 1990 to come to Europe. What Europe doing something, and they don't have program in 1990. Few countries, they have a program in emergency medicine. And I met one of the leaders is Dr. Herman Deleuze and David Williams, and then met Dr. Pateron in France, and then we went to different conferences with the other part of the Europe, and also I met Roberta Petino. I don't saw her, but she was involved in many organizations of the conference, and she was the past president of SEM. And also, what is the reference if you want to study emergency medicine, because you don't have books. You have internal medicine or surgery. So we're looking for the guys, they have the New Testament and the Old Testament. Peter Rosen, the 3 tomes for the books in emergency medicine, and Judith Tintinelli for the books to learn. And also I write my own book. Now we have 3 of the people that write books for emergency medicine in the rest of the world. So in 1990, I invited the first time Judy come to Mexico, because we need to get reference how emergency medicine doing outside of Mexico. And this is why I invite her to come and participate. But this is the evolution in the rest of the country, in the rest of the world. We are the same. You speak Turkish, I speak Spanish, this guy speaks English, but the evolution was the same. We start like monkeys, and now you look tired, you look handsome man and pretty woman. But at that time, nobody believed in us, and this is the normal evolution and that we have. Until here, I saw many leaders that I know for the last 30 years doing these things, and very interesting points. But remember, those who cannot remember last, they are condemned to repeat the same mistakes. So be careful. The younger guys, if you want to do something, pay attention in the people was before of you, because you don't need to make the mistake, and you advance quicker than us. And remember, the doctors and emergency physicians is like the wines. The more older, the better. Emergency medicine is this style of life. I lived 33 years like emergency physician, and I feel fine. I feel very well, like many of you. And I made a lot of friends. The life is not only emergency room. We need to socialize. This is why many people organize now conference. We need to outside to the emergency room, share, dancing, praying. And I met many people over the years. And remember, welcome, everybody is welcome for the National Congress in Emergency Medicine in Mérida this next November. Thank you.
Thank you, Carlos Garcia Rosas, for your opening remarks. Now I would like to invite Professor Roger Dickerson, President of the Emergency Medicine Society of South Africa.
Merhaba. Güney Afrika'dan selamlar. What I should also be saying is I'm learning some Turkish, so I'm going to teach you some isikoza. What we refer to as a conference in isikoza is umbuzo. Now everyone, let's try together. Buzo. Now put it together. Umbuzo. And what an umbuzo is a time for the wise to learn from the young, and a time for the young to learn from the wise. And note there's no mention of old, it's only wise. And that's what this is all about. Now, you know that I come from the southern tip of the African continent. We have strange creatures like the Big Five. Now, the undoubted king of the Big Five is the giant cat called the lion. And I think Professor Canlı is your version of the lion, certainly the king of the jungle in these parts. And it's a pleasure to be part of a conference that you've once again organized so incredibly well. But it's something that we can, as emergency physicians, and it's been interesting hearing all of the previous speakers standing up and saying, almost like an Alcoholics Anonymous meeting, going, I'm an emergency physician. But I think it's something that we can learn from the Big Five, because in order to survive in emergency medicine, you need to have the courage of a lion. You need to have the cunning of a leopard. You need to have the stubbornness of an elephant. You need to have the patience of a hippopotamus. And then, when our patients' lives depend on it, you need to have the temper and aggression of a wounded rhinoceros. Because that, and it's something that Jill mentioned earlier, we need to be advocates for our patients. And I think that's what we're all here to do. We're here to learn, we're here to develop. We're here to take the specialty that has been carved out so delicately and enhanced. I was standing chatting to what have become really good friends, and it was really the past, the present, and the future of USAM. And in fact, they're starting to talk about not just the past, the present, and the future, but the past, the present, the future, and the future. And that's really where we should all be looking towards. And so I would like to express my sincerest appreciation to the organizers, not only for tremendous hospitality, but the amazing opportunity for me to learn from the wise, and the wise to learn from me. So thank you very much to the organizers, and congratulations.
Thank you, Roger Dickerson, for your opening remarks. Now I would like to invite Dr. Hikmet Anvarov, Deputy Director of Emergency Health Services of Ministry of Health of Uzbekistan.
Thank you. Merhabalar, günaydın. Sayın Profesör Candır, sayın kardeşler, ata yurtunuz Özbekistan'a sıcak selamlar. Ben için bu kongrede konuşmak büyük onurdur. Dear ladies and gentlemen, it's a great honor for me to stand here on this fabulous place and greet you from my personal and from all entire system of emergency medicine from my country, which I will be happy to introduce you in this part of the world. Tomorrow I will have an opportunity to talk about more detailed about my country, about the system of emergency medicine in Uzbekistan. But today, as per our tradition, with your kind permission, I would like to present a small gift to our common host, Professor Bashar Jander. This is not just a part of protocol. This is not just a part of our culture, which is, but it's pure and sincere symbol of our appreciation and gratitude.
Thank you very much.
Thank you very much, and I wish all of us successful and fruitful Congress. Thank you.
Thank you, Hikmet Anwaro, for your opening remarks. Now I would like to invite Swaminathan Mahadevan, Professor of Emergency Medicine at Stanford University.
The confusion, everybody who meets me in my life, they go, he's Indian, but when he opens his mouth, he sounds like an American, and that is because I am both. I am both. First off, I want to extend my sincere gratitude to Dr. Bashar Chander and the organizing committee for inviting us to this fantastic conference. As you can see from all the luminaries who are here speaking at the conference and just the agenda, it's going to be a fantastic Congress. It's my 5th time to Turkey and 2nd time to Antalya, and I'm very excited to spend the next 3 days with you. Just reflecting on what some of the other speakers have said, when we get together as emergency physicians, our histories, our challenges, our successes are mirrored in each of the countries that we work in. And I've had the privilege of not only being an emergency physician and a teacher in the United States, but traveling to other countries like India to help with the development of emergency medicine and emergency medical services. And I would hope that you take the time, since we're all here, have come so far, to spend these next few days with you. Go reach out to these folks. They are very kind and accommodating and want to talk with you. I would encourage all of you, the participants, the delegates, to speak to all the faculty who have come from around the world and share your stories, and so we can do the same. And I want to wish the organizers a fantastic conference. I want to thank you again for being invited to speak. Thank you.
Thank you, Swaminathan Mahadevan, for your opening remarks. Now, I would like to invite Professor Wang Zhang, President of the Chinese International Exchange Association of Emergency Medicine.
afternoon, everyone. Dear Professor Basa Canlı, ladies and gentlemen. I'm Dr. Wang from China, and I'm chairman of the emergency branch of the International Exchange and Promotion Association of Medical and Healthcare. First of all, I would like to say that we are very happy to be invited by President Basa Canlı to come to the beautiful Turkey. This is the first time we are here, and last night we got into the hotel at 1 midnight, so we can see nothing. And this morning, when we get up, we saw that everyone are beautiful. So we hope that we can come again. In 1983, China established the emergency medicine. After several decades of development, it has formed a relatively complete emergency medical service system, including the pre-hospital emergency department, and EICU. So we are very happy to share some experiences with our international counterpart and all of you here. And we also hope to learn from you and from everyone the experiences and improve together with the colleagues of emergency physicians. The 2019 annual meeting of our society will be held in Hefei, Anhui Province on October 13th. We seriously invite every one of you to visit China and to join our meeting. And besides, we take a small gift and a formal invitation letter for Basa Canlı and the Association of Emergency Physicians of Turkey.
Thank you very much.
And we wish this conference be held completely success. Thank you very much.
Thank you, Wang Zhang, for your opening remarks. Now I would like to invite Professor Paul Kivilla, President of the American College of Emergency Physicians, ASAP.
Never quite sure what the music's going to be. Earlier I was told it was going to be 50 Cent. So I was going to try and figure out how I was going to rap my way up here to the stage. So thank you again. I'd like to thank the organizers of this conference for the wonderful hospitality. And on behalf of the 38,000 emergency physicians of ACEP, I would like again to say my thanks for being here. This past year, we were founded in 1968, so this was our 50th anniversary. And as we go forward, it was great to hear what a lot of the speakers prior to me had already said. And I want to say much of the same things. I think, this is just a wonderful conference here where there's an opportunity not just to learn, but also to collaborate and work together. It is my opinion and that of our organizations that emergency medicine has no borders, that we are a world community and we should learn and work together to advance our specialty. We are one of the youngest specialties, but we've matured very, very quickly. And in many parts of the world and the United States, we are now seen as one of the leading specialties that advocates not just for ourselves, but most importantly for our patients. I think that there has been a lot of collaboration that we have started on our side here in the past year, and I look forward to working together with many other organizations, including EPAT and USIM and many, many others, of how we can work together and move things forward that we can advance research, that we can advance learning and advance technology. In the United States, our residents are very unsure what the future holds. And I think this is a great opportunity because we are doing research to look at not where we're at right now, where we're going to be in a year, but where we're going to be in 30 years. Because that is about the lifetime of an emergency medicine trained physician, of how long they work. So we have to think forward that we're training them the right way. And if you look in the United States right now, and this is going to be a world issue, technology is going to change very quickly. And we believe that emergency medicine is no longer all going to be delivered in the emergency department. That we believe emergency medicine is a specialty and not a place. We're already seeing a lot of our graduates go into technology, deliver things via telemedicine, and we think that the future is only going to be brighter in all those regards. And our specialty is the one that usually adapts the most quickly. So I would like to thank everybody for here, and I hope to reach out to you here in the next several days as we talk about how we can work together, because I truly believe that we can learn from each other. And also, I'd like to thank Dr. Bashar Kanner. I'd like him to come up here, as we have a gift for him as well, is that, here's someone that is bringing the world together. And I think, here, this is their 15th anniversary of their conference. But the scope of the leaders that are here, the scope of the training that's going on here is really exemplary. And Dr. Canlı, will you please come up? And on behalf of the 38,000 members, this is a plaque that just honors the contribution that EPAT has made to emergency medicine. Also something you can put on your desk or your nightstand that will also remind you of our very much appreciation to what you've done for our specialty. Thank you.
Thank you, Paul Kivila, for your opening remarks. Now, I would like to invite the mentor and the constructor of the emergency medicine training in Turkey and the president of the Emergency Physicians Association of Turkey, İPAT, Professor Başar Candar.
değerli arkadaşlar, sizinle burada bulunmaktan çok büyük bir mutluluk, onur ve gurur duyuyorum. Tabii yabancı konuşmacılar var, unuttuk. Onların da trans şeyleri var değil mi? Tercüme şeylerini verdiniz. Yani şu anda gerçekten bir yıllık büyük bir gayretin sonunda son derece büyük vakitler, efor, emek harcayarak böyle dev bir organizasyonu geliştirdik ama şurada gördünüz siz de. Burası artık diğer katılımcılar da kabul eder ki dünyanın acil tıbbının birleştiği yer olmaya aday bir yer görünüyor değil mi? Aday bir ülke olarak duruyoruz. Dünya acil tıbbını birleştiriyoruz. Dünya acil tıbbının birleştiği yer gibi bir görev üstlenmiş durumdayız. Burada zor konuşuyorum, biraz zor başladım. Niye zor başladım? Çünkü çok değerli, çok büyük bir hocamız aramızda. Onun önünde ilk defa konuşuyorum. Hocam bizi mazur görün. Sayın Profesör Doktor Bingür Sönmez hocamız bugün aramızda. Lütfen alkışlarımızı. Size çok güzel bir ders anlatacak. Burada yani gerçekten çok güzel vakit geçireceksiniz. Bu yılki kongremizde de bazı yenilikler var. Onlardan size bahsedeceğim. Tabii acil tıpçıları bir araya görünce herkes konuşmak istiyor. Çok konuşmak istiyor. Çok güzel şeyler anlatmak istiyor. Sayın Carlos'un dediği gibi yaşlandıkça daha değerli oluyorsunuz. Daha değerli şeyler anlatmak istiyorsunuz. Ama ben artık acil tıpta hep acilden bahsetmekten yoruldum. Ben de size bugün olimpiyatlardan bahsedeceğim. Olimpiyatlar ilk olarak ne zaman başlamış arkadaşlar? Bilen var mı? İlk olimpiyat 800'lü yıllarda. Peki bu olimpiyatta bu 5 halka neyi temsil ediyor biliyor musunuz? Bu 5 halka neyi temsil ediyor? Bilen var mı? Şey sorusu değil mi? 5 kıtayı temsil ediyor. Biz ne yapıyoruz burada? Biz de 5 kıtayı, hatta 6 kıtayı temsil eden bir organizasyondayız. Yani buranın bundan sonraki ismi ne? Acil tıp olimpiyatları değil mi? Acil tıp olimpiyatlarında bundan sonra hep bir arada olacağız. Acil tıp olimpiyatları. Kıtalar bir arada, hepimiz bir aradayız. Peki bu olimpiyatlarda, olimpiyat deyince aklınıza hangi yarışlar geliyor arkadaşlar? Mesela hangi sporcular aklınıza geliyor? Sporla çok ilgileniyoruz değil mi? Mesela ilk akla gelen herhalde kimler var burada? Michel yüzmede bakın 29 altın değil mi? Kaç? 23 altın. Larissa, Muhammed Ali Kılay, boksta, Usain Bolt. Bu isimleri aklınızda tutun. Bu isimleri aklınızda tutun. Burada ne görüyoruz arkadaşlar? Kim bu? Usain Bolt. 9.58 ile rekor kıracak değil mi? İlk aklımıza gelen atlet neredeyse bu. 100 metre yarışı. Olimpiyatların ruhu mu neredeyse bu? Bu rekor. Tek olimpiyatlar bunlarla ilgili değil. Güreş de olimpiyatlarda çok önemli. Gördüğünüz gibi.
Harika bir hareket. Bakalım süre yeterli olacak mı?
İşte bu an. Değil mi? Galibiyet anı. Ama başka sporlar